The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. It's a real pleasure to be able to welcome Pat Cartwright back onto the podcast. Pat's one of those people who always makes me feel smarter because he's smart enough that he explains things extremely well, and I appreciate that a lot. Welcome back, Pat.
Hey, thank you, Paul. It's good to be back.
I can't remember if we were talking online or offline last time about the Ashton to Teutonia Rail Trail in Idaho, but whenever I'm on it, I think about you because I spend a lot of time up there, and I know you've ridden it before.
Good for you. I look for any gravel trail or other trail I can get on. As I'm getting a little older, those are friendlier, so I'm glad you're having fun out there too.
It's a little bit more civilized, isn't it?
Indeed.
And a magnificent view. Well, we wanted to talk this month about some more topics related to urology, and today's topic actually came from, I think that one of the things that you've done a great job, other people have done a great job, is to assemble some of the concerns that come in both from generalists and specialists. And we want to talk a little bit more about this first topic because it's something that comes up, if I'm reading the situation correctly.
Yeah, I think that's true, Paul.
All right. Well, so this week we want to talk about undescended testes. Before we start, do you have any disclosures that you want to share?
I do not.
Well, then let's get started. So it seems like an easy question, but we're going to complicate it as we go on. What is the definition of an undescended testis?
A testis that's not fully located in the scrotum is considered undescended, potentially could be ectopic, but you basically need the full body of the testis in an interscrotal position for it to be considered descended.
And that's different from agenesis or atrophy?
Different than those, correct.
What happens physiologically that a testis doesn't end up where it belongs?
A lot of people have looked at it and studied it. It probably involves several factors. I would say the two overwhelming things are, maybe three: a structurally abnormal testis. So they tend to have more detached epididymides, smaller testes, structural problems that don't allow the testis to descend properly that are intrinsic to the testis. That's one sort of predisposed group. The other is those with something that disrupts the pituitary gonadal axis, so central brain development lesions. And the third is probably abnormal abdominal wall. So kids with things like bladder extrophy, prune belly syndrome, gastroschisis, those are all probably physical impediments to descent. So there's several things in there, from normal structure to normal testis to normal endocrine signaling. And those can be off to different degrees in different kids.
And just a quick reminder, why does it matter?
Probably the two big things. So overall, an interscrotal testis, if you measure intratesticular temperature, is 2 to 4 degrees cooler in the scrotum than outside the scrotum. And particularly the spermatogenic elements within the testis are sensitive to that in the long run. So the biggest effect is on poor testicular growth and volume, which mainly means poor spermatogenic potential for the future and infertility issues. The other related issue is cancer risk, probably a little less temperature dependent, but undescended testes that remain high have a higher long-term risk. And once they're brought into the scrotum, that's better. Those are the two biggest issues.
So obviously, when you can't find a testis in proper position, let's talk about some of the ways we can approach that. When is watch and wait the right choice?
So certainly when kids are born, the incidence of testes not being in the scrotum is 2 to 3%, so fairly common. And the more premature they become, the higher that risk is. If you get to a 30-week preemie, about 40% will have testes that aren't in the scrotum. Essentially, they're here before the descent would have occurred in that percent. So you generally wait out kids after birth till at least 6 months of age. Testes tend to move substantially, mostly in the first 3 months, maybe with that little normal postnatal testosterone bump that kids have at weeks 6 to 12. Maybe that's the signal for them to come lower. After 6 months, rarely do you see them come lower. And that's a point where thinking about management and approach sort of comes into play.
In terms of waiting until you think it's going to show up, it sounds like 6 months makes a lot of sense.
Yeah,
Well,
that's the one.
What's the critical time period for when you really ought to do something about it? When are we at risk of allowing damage to happen?
Yep. So the American Urologic Association and the European Association have very similar guidelines. It should be referred at or before 6 months of age if both testes aren't palpable in the scrotum. And intervention should occur before 18 months of age. That's what the guidelines say. Now, the practicality and some of the science behind it suggest earlier. There's been a series of undescended testes studied at the time of surgery at different ages, biopsies done of the undescended testis, and examination of whether the normal gonadocyte to spermatogonia transformation is occurring, which happens early. And it really starts to get delayed around 6 to 9 months of age. So the idea is the sooner you get to that, and before then, undescended testes have a pretty normal histology. So most surgeons are looking at the 6 to 9 to 12 month range rather than older because of some of the histology we see. And the other thing that goes with that, Paul, it's hard to get great prospective studies, but there was one really lovely one out of Europe where they performed orchiopexy between 6 and 12 months of age and compared that, and it was randomized to between 2 and 3 years of age. And they followed annually with ultrasounds, and you ended up with distinctly better volume, more similar to the normal descended side in the early group. And they're watching those kids now into puberty, and they're going to do sperm assessment later on and fertility follow-ups. So a really great study in a prospective group, I think that'll give us some better answers. But so far, a lot of things point to doing it sooner rather than later.
Sounds like a pivotal study for something that's been around for a long time, right?
You've been doing this long enough to know also. It's amazing how infrequently we have the great definitive studies and even common things. So, when I talk to students about, well, I don't know if I want to do that study, it's probably already been done by somebody. My answer is often, probably not, and probably not well.
Yeah.
And then in our specialty, probably not followed up for the period of time required to have the answers we want. And that's a big thing with undescended testes. I mean, you need 50 years to look at the cancer risk and 40 years to look at all the fertility answers. So it's a big time window and takes a lot of commitment to do it well. So I'm looking forward to the study follow-up here in a few years.
And the importance of all this is that, if you think of the back to sleep thing as the paradigm for this, sometimes popular wisdom is exactly wrong. And doing the study of things that we think we understand is absolutely pivotal.
Completely right. I agree with you.
Yeah. All right. A few years ago, it seemed like there was frequently a practice of recommending a trial of hormonal therapy for cryptorchidism. What's become of that?
So in short, not recommended. The guidelines, European and US, it's no longer recommended as a therapy. And essentially the issue is that it has a low response rate. Some of the early studies had higher, more promising response rates, but in those cases, it's sort of felt now that a lot of the pre-op assessment was wide and broad. It included, family practice docs seeing kids and a whole set of people diagnosing undescended testis, and maybe it was not correct all the time. And so if you have a retractile testis, they tend to respond well to hormones. And when you actually look at truly undescended testes, it's probably under a 10% response rate, maybe under 5%. And of the ones that came down with hormone therapy, about 50% of them ascend to a higher position when you stop. So overall, just not worth the effort and the exposure. So not recommended.
I guess if time matters, that's significant. And this is another one of those things that I've really come to appreciate in the years I've been doing this podcast, is that collaboration matters, that getting you guys involved matters.
Yeah. The other thing with it, Paul, it was a series of 6 to 10 shots over weeks, sometimes bumped their testosterone, made them grumpy, side effects, and just in the whole mix of things, not recommended at this point.
Well, let's talk then about some specifics. So a diagnostic approach to missing testicle. Let's start with category A, and that's that there's a palpable testicle that's not in the right place.
Okay.
What do we do with that?
Yeah. So if that's the case at birth and the child has a normal penis, normal development, that's a wait and watch. And that's a refer to us at 6 months if that thing doesn't feel like it's in the scrotum at that point. And again, by in the scrotum, we mean full testis, full body of testis in scrotum, hopefully mid scrotum, but upper scrotum is probably okay to watch a little longer. But at 6 months, if it's not down, those should be referred in.
Okay.
The caveat to that is unilateral undescended testis, even if palpable, but especially if not palpable and associated with any penile abnormality that's along the hypospadias realm, like minor hypospadias, moderate, cleft or abnormal foreskin. That kid probably deserves an earlier evaluation, as a certain percentage of those will have an underlying disorder of sexual development, a few percent when you're talking unilateral.
So let's repeat that again. So a unilateral undescended testis with any penile anomaly.
Correct. Those should be referred in early for evaluation. We actually have at primary now a multi-specialty DSD clinic, which has been useful. They have social work and genetics there and endocrine there and urology there. So it's a nice group for more complex kids. A child like this probably just coming to urology first to see if we're really talking about hypospadias, what the testis feels like. There's a set of DSE diagnoses that can be associated, and it may be worth looking into those.
Let's just define the term here too, because DSD, differences of sex development, is a term that has really come into favor over the last 15 years or so. But that doesn't mean that we've all caught up with that. And so it's been called a lot of other things before, but any differences of sex development.
Yeah, that's true. Intersex obviously was the most common term before. That's fallen out of favor. There's a whole set of potential diagnoses under there. Congenital adrenal hyperplasia being one of the common ones. That wouldn't present with unilateral unpalpable testis. That would be a bilateral unpalpable testis. So in that case, that definitely warrants perinatal evaluation for sure, since those kids are at risk for adrenal insufficiency and other issues. So that's the second group, bilateral non-palpable.
Yeah. So two things back on the unilateral one. Is imaging something that I should consider for that?
That's probably one of the reasons that I asked Paul if we could do this is I think still in our community, there's a lot of what I would consider misuse of imaging studies for undescended testis. So it's pretty simple. You should not order ultrasound imaging before referral. And there's probably two reasons for that. One is that I think often we can feel a testis where you may not. I didn't know what I would be good at in life, and I didn't suspect this would necessarily be it, but being a pediatric testicle wrangler is one thing I think we get good at in peds urology. And the testis exam is hard, right? Like all of our residents struggle with it when they come on peds and try to learn it. And so totally understand the challenge there. So sometimes we'll feel one if you didn't in the non-palpable case, or we'll feel something different and think it's more normal than you will. So that's one thing. Sure. The other is when you look at ultrasound, it really has bad stats in terms of looking for undescended testes. The sensitivity for an abdominal testis is around 50%, and the specificity is only about 75%. When you look at it, it has very little marginal benefit in terms of determining next steps. Almost always, if an ultrasound says the testis is not present, there's still a 15% chance there's an intra-abdominal testis. If it says it is present, we probably are going to know that by exam, and our approach surgically is going to be similar with or without ultrasound information. So refer them in and don't do scrotal ultrasound. Multiple publications, really good one in Pediatrics in 2011 that basically looked at all the data and said not of benefit, and probably over $100 million spent on it a year. So ability to increase value and doesn't change care at all in the majority of cases.
Any tricks for looking for what may be a highly retractile testis instead?
Yeah, probably the main thing is stuff pediatricians are good at anyway, is having the kid relaxed, on the table. And I think the key thing with testis exam is always with your offhand, start it over the internal ring of the canal and sort of push distally. So any testis that is in the canal, you push out of the canal to a lower position. Then keep your non-examining hand right over the canal, because when you go to check the testis, it loves to pop up in the canal and you'll miss it. So do that first. So it traps it in the lowest possible position. And then I think the key is feeling in a deep location and not superficial. Almost everybody starts, with a little scrotal skin pinched between fingers, and you won't find it there. You have to get fingers down almost onto pubis and feeling really deep tissue to feel it. Probably the key things.
By the way, I refer to what you folks do as search and rescue instead. You folks are the Navy SEALs of testicle rescue. So
I like that. Everybody has to have a thing, Paul.
absolutely. Let's talk about the bilaterally non-palpable ones. And you've mentioned the differences of sex development. And your advice there would be we should start talking right away if we can't find either testis, right?
Correct. Even with a normally developed penis, with bilateral non-palpable testes. I mean, I've seen two kids with XX patients with congenital adrenal hyperplasia who had a normal enough phallus that they were circumcised. So, that can definitely be something that'll throw you off. So bilateral non-palpable testes deserves early evaluation for CAH, and usually the screening is a 17-hydroxyprogesterone level. Those patients we may also do imaging in, but talking to us early and probably the endocrine team makes sense because, as you know, those kids can get sick within a few days or first week of life if they have salt wasting associated issues and can have an adrenal crisis. So knowing about that early is super important. So bilateral non-palpable early evaluation.
And some of those kids may actually have true undescended testes, but there again, I'm guessing statistically that if they're both undescended, the likelihood of them arriving is lower.
Yeah, definitely true. So the higher they are, the less the chance of descent over time. So the ones that you hold out the most hope for in terms of making it to a scrotal position, not requiring us to do anything surgical, are the ones that start low from the beginning. You can feel them, they're almost there. Those are the ones that definitely tend to make it into the scrotum on their own, and you can leave them alone. And it's probably of the ones that are truly undescended at birth, only about 30% in reality make it to the scrotum. Sometimes people have estimated higher numbers, but that's probably the more accurate number. 1 out of 3 do, 2 out of 3 don't. The higher, the lower the chance.
What's the difference between anorchia and testicular atrophy?
So testicular atrophy turns out, so for a non-palpable testis, there's sort of 3 possibilities. One is that it's in the abdomen and you can't palpate it, but it's present and developed. The other is that it's not there at all, testicular agenesis, which is fairly rare. And the third is it's atrophic and it's too small to feel. So agenesis is more profound embryologic defect where the testis on the urogenital ridge never formed from the beginning. The more common thing is you don't feel it, but there's actually a small atrophic testicle there that probably had a vascular event during descent through the canal. And sometimes that's bilateral and is a really tough thing. So it's basically like a prenatal torsion issue with atrophy of the testis. And essentially, probably 9 out of 10, if there's not a normal testis present, it will be atrophic rather than true agenesis. Agenesis is fairly rare. Atrophy is pretty common. We're talking about kitchen match head size testicle, often firm with dystrophic calcification in it. And sometimes we can feel those little nubbins, so-called nubbins, on persistent sort of careful exam, or in the OR if we're there asleep looking for non-palpable testis, we'll feel when they're asleep. And if there's a little tiny structure there, almost always it turns out to be an atrophic testis that we'll remove it for there surgically. Not really probably much risk of it being there, but it's sort of, you have to make the definitive diagnosis, and that's how it's done.
Yeah, very interesting. I also found that one of the great advantages of having you folks involved from an early stage is that once a baby has developed anything like a prepubic fat pad, it all becomes more difficult.
That's all true. Yeah, definitely a true thing. So the other thing I would sort of, is we're talking about all the different categories, Paul, in terms of timing of referral, despite the guidelines that we just talked about, which is send them in by 6 months, then we operate before 18 months. And I've sort of told you, almost all of us now in pediatric urology are before 12 months based on a lot of the data out there. We see a lot of patients referred at older ages. And, that's a concern. If we're talking about how profound the fertility issue is, it's pretty amazing how much being undescended can affect a testis. The kids who are really at the highest risk are bilateral undescended testes, and the higher they get, the higher the risk. If you have intra-abdominal testes, bilateral, not operated on until kids are 3 to 5 years of age, they have a almost 50% chance of having a 90% loss of basically the spermatogonial stem cells that will form spermatozoa later on. So a profound potential effect on fertility. And the bilaterals are really more affected. Unilaterals have a similar effect on the high testis, but with a contralateral one, when you look at their sperm count and paternity later on, the unilateral undescended testis, without regard to the age it was brought down, can have a fairly good potential for fertility later on, whereas the bilaterals are pretty profoundly affected.
It's incredibly important.
It is. My partner, Chad Wallace, looked at the data, and at least a third of our kids, close to 40%, were referred late. And many of them are 3 to 5 to 7 years of age. And I think there's probably 3 different things that affect that. One is uncertainty on exam of the PCP or the pediatrician involved. Like, I think it was okay. I'm not sure. Maybe we'll wait it out another year. The other we hear from lots of families is that we're not really sure our pediatrician or PCP checked very often over the last few years. And, you can see how it happens in a busy practice. And, that there should be at each well-child visit a palpation of the testicles. I mean, that's in all the guidelines also. And I think is incredibly important. And then the third, and I think we're getting to it, is there are some testes that will be in adequate position early on and end up in a higher position later on. That's become a much more recognized phenomenon over time. So,
yeah, tell me about ascending testis.
Yeah, it's an interesting. We used to think it was pretty rare, but as people have watched it more carefully, there's probably something like a 10% risk of testes moving to a higher position over time, especially the ones that were undescended to begin with and made it to a lower position. About 20% of them, it seems, will end up in a higher or unacceptable position with growth over time. That's a distressing one to pediatricians they've seen them 3 times. They've documented good position of a testis. And now, the kid's 5 or 7 and there's one that's missing and they're looking back through their notes. So totally get it. They do. There's probably several reasons it happens, but some do end up fixed in a higher location over time. And that can affect growth, probably not as profoundly as being undescended since birth, but orchiopexy, again, is the best solution for that and has the data that shows best growth and catch-up growth over time.
No, I was talking to a colleague about what we were going to talk about. And he said, I have a kid who has haunted me forever because I thought I had felt it before, but I must have just missed it. And I said, well, it may not be quite that simple.
Yeah, I think that's right. And I've gotten calls from people like you, like experienced, thoughtful pediatricians who've been at it for a while and like, how did this happen? Did I miss it earlier? Do you really think it was down or were my notes wrong? I worry about cut and paste of notes too, right? Where at one exam it was down and people just carried that on. So who knows exactly? But I think the point maybe is I would love to see us as a community prioritize checking with each visit and potentially referring earlier and getting these kids taken care of to assure best possible fertility.
Absolutely. So just quick run through of some things we've talked about. Referring kids to you, palpable cryptorchid testes ought to see you
6 months of age.
One side non-palpable.
If the penis is normal, 6 months of age. If the penis is abnormal, where we're now getting into the possible DSD realm, in that circumstance, it's maybe up to 10 or 15% that we'll find some sort of genetic defect or developmental issue that's of importance. So if their penis is abnormal, let's see them as soon as you put those 2 things together, non-palpable, abnormal penis, send them to urology then.
Perfect. Bilateral non-palpable.
First week of life.
Ascending, wandering testes.
When you diagnose it, we'd love to see them at that point. And I would say anytime there's a concern with the position of the testis, we're happy to check them. Like you're just not quite happy with it. We love to see them and be part of the decision-making because it's hard. And I think it's one of those things that there's a lot of perspective on the small aspects of the exam. Like, is this really okay? Or am I inappropriately worried? So we're happy to be involved in those at any point.
The ideal phone a friend, right?
Yeah. Again, it's got to be good at something. I hope we're good at that. We certainly examine a lot of tests. I'm probably up to my 10,000 testicles at this point, Paul.
But think about it, Pat. In very real terms, you're rescuing grandchildren. Way to go.
You're feeding the ego. We like that.
Yeah, that's a good thing.
So the one thing we didn't talk about was the diagnosis of retractile testes.
Yes.
So that's a pretty common thing, and that's just an active cremasteric reflex. So generally those kids will have testes that are down early on. They come back for their 2-year visit or later in life. And now, again, this is the pediatrician looking back on notes like, did I really feel it before? Cremasteric reflex gets maximally active between about 18 months and 6 years of age. So at least half the kids, when you examine cold stimulus, cremasteric reflex pulls testes to upper scrotum or even higher. If you can examine like we talked about before, press on the inguinal canal, get everything down, mobilize testis, and it drops to a mid-scrotal position and stays there until you again stimulate the cremasteric reflex, that's retractile. Retractile testes don't affect growth of the testis. You can leave those alone. But like the ascending one, and it's a variation on the ascending one, right? A few retractile testes will end up stuck in a higher position later on. So we used to tell them, retractile, you're okay. Let your pediatrician know if you ever have a worry, if there's pain or swelling or anything like that, but you don't have to come see us. Now the recommendation is annual exam until they get to probably 3rd grade, like 8 years of age, which is where a lot of the reflex wanes. And so our usual approach is if we see them, it's clearly retractile. We set an appointment for them for 1 year to come back and see us. But we usually say, if when we call you in a year, your pediatrician is now confident they felt it down, it's not an issue, you don't have to come back to see us for that exam. But if there's still a question, please do, and we'll double check. And so we're seeing a number of those patients back and watching over time, which I think is smart. I think it's a little more impactful than we thought in the past.
And to be honest, it's an exam that can be quite difficult because, an 18-month-old is a difficult exam in general. And, you're dealing with all of those other sorts of issues. So, yeah, it collaborates.
Very true. I would say similar to our philosophy for doing a circumcision on a penis you're not quite sure of the anatomy with, we'd love to see them, work with you on, yep, that's good, do it. If you're not sure about a testis, same thing, just send them in, we'll check it. And we'd rather do that and make sure and coordinate the care with you than for you 3 or 4 years down the line to regret not having set one in that turns out to be an issue.
Yeah, 100%. You guys are always great at that. For those of you who have questions, please send your questions to questions@vcurb.com. We'll deal with those in a couple of weeks. And Pat, we'll talk again next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.